Good afternoon, everyone. Welcome back to our third day of and also the final day of Southeast Asia and the Western Pacific bi-regional FETP COVID-19 online conference. I hope you all enjoying the today's meeting. And today we will have one oral presentation session and one keynote speech. Now I would like to hand over to Dr. Martyn Kirk to moderate the oral presentation section. Dr. Martyn.
Thank you, Dr. Wan Chin. Welcome, everybody. My name is Martyn Kirk.
Martyn, you're on mute. Martyn, could you unmute, please?
Thank you very much, Carl. Hi, my name's Martyn Kirk. I am an epidemiologist and I'm a professor at the Australian National University. I'm also the acting chair of the advisory board of TEFINET. It's a great pleasure for me to moderate this session today. I would ask that everyone mute themselves if they're not presenting, so that we don't get background noise. We have 4 presenters in this session today. There will be 10 minutes for presenters to go through their slides and present their material, and then we'll have 10 minutes of questions which people can use the chat. So without any further ado, we will start with the first presentation, which is Ngoc-Anh Hoang Thi from the Master of Applied Epidemiology program in Australia, and she's based in Vietnam as an ASEAN fellow. She's going to be presenting to us on investigating COVID-19 transmission in a tertiary hospital in Hanoi, Vietnam, using social network analysis. Thank you very much, Ngoc-Anh.
Thank you. So can I start?
You can start.
Okay. So hello everyone, my name is Hoang Thi Ngoc-Anh. I'm a scholar of Master of Applied Epidemiology at Australian National University and Vietnam National Institute of Hygiene and Epidemiology. Today I'm sharing to you a presentation entitled Investigating COVID-19 Transmissions in a Tertiary Hospital in Hanoi, Vietnam, using social network analysis. Next. Here is the outline of these presentations. We will go through 4 sections, from background and aim, methods, results, and conclusions. Next. The first of COVID-19 confirmed case in Vietnam was in January. However, we experienced the first case in a healthcare facility 2 months later. It appeared in the largest hospital in the northern Vietnam, with the capacity is more than 1,400 beds and over 4,000 staff. Quickly after the confirmations, the National Steering Committee of COVID-19 Prevention incorporated with the hospital to investigate the disease sources to control this situation. Next. In this project, we aim to study the transmission pattern during this outbreak with the support of social network analysis. Next. We take data from 3 sources. Case interviews to know about the exposure, the connections among other cases, and the list of close contacts. We check PCR testing from testing management system of the from the National Institute of Hygiene and Epidemiology. And we got data of movement monitoring, the mobile checking, and video surveillance to fill the contact tracing list. Next. So to support for studying disease transmissions, we use social network analysis. For people who are not familiar with this term, in the couple of next slides, I will show you some basic information about what network is and why we want to study network. However, this is a complex term and hard to explain all in some slides. I suggest some additional information of social network analysis for those who would like to learn more about it. Basically, a network is a set of objects which we call nodes that have some relationship between each others, which we call edges. For this project, a node is presenting for a confirmed case, and an edge indicates the relationship during the infection time among cases. Next, The objective of social network analysis is to find important cases in a network. However, there is many ways to think about the word importance. Each metric of network will decipher the word importance in a different way. In this study, we use three most common metrics of the network: the degree centrality, between centrality, and chronic centrality. In the next slide, I will show you some basic information of these metrics. I performed the analysis using R with the iGraph and CNAR package. Next. So one way to define the important nodes is case who have a lot of friends. So the degree centrality makes the assumption that important nodes have many connections. Okay, what have a centrality of 1 if it connects to every single node in the network, and a centrality of 0 if it connects to no node in the network. For example, case number 27 have a degree centrality of 10 because she contacts with 10 other cases during their infection time. Another way of measuring importance is nodes who have very close to other nodes in the network. And the assumption here is that important nodes are going to be very short distance away from all other cases in the network. And the other way of thinking about importance, what we say that important nodes are nodes who have tend to connect other nodes in the network. So we could imagine measuring the importance by the fraction of shortest path that pass through a particular node, which we call between this centrality. Next. In there, we are going to cover what we did to control this outbreak in Vietnam. We did a blanket and chain testing, more than 7,000 tests among nearly 2,000 people inside the hospital. Because this hospital have a large number of patients and caregiver visits and examinations, it's reasonable to concern about the local transmission in community at that time. The board of hospital director decided to extract the list of outpatients who visit the hospital in March. Then they send them to CDC in 49 provinces for chasings. More than 26,000 people were tested. Next. We confirmed 45 positive cases related to this outbreak. Most of them were in middle age and female. Ancillary support staff made up to nearly 60% of total cases, while the rest of profession is minor. The important is that 23% of total number of ancillary support staff inside the hospital were positive for SARS-CoV-2. The hospital issued many interventions to control the spreading. Right away after the date of index case confirmations, all staff and people inside her department were tested for SARS-CoV-2, and her department was stopped examination for outpatients. And 12 days after the date of first case detection, all people in the hospital were tested for SARS-CoV-2, and the hospital was locked down for 21 days. Next. Here's the outline of the hospital. The red border indicates the regions where the cases were confirmed, and the number inside the red circle is to depict how many cases were placed in this area. For example, in the supermarket and canteen area, 26 cases were confirmed. You can see in the bottom of the graph, the first index case were in Tropical Disease Center in a nurse. Within nearly 2 weeks later, it expanded to other 6 different departments. As you can see in here, the infected areas in North Crater is scattered around the hospital. Next. There are some graphs of X metric that I mentioned earlier: degree centrality, between centrality, and chronic centrality. In here, the ancillary support staff are presented in the red color, while the dark blue color for other cases. Among 45 cases, a total of 67 connections were detected, and the crucial case of transmission network was case number 27. She is ancillary support staff who linked to the most other case in the network. In other words, if we remove her, it's called the network fracture and break up into different components. Among 10 most important cases selected by each network metric, the transmission dynamics cluster in 15 cases. 60% of them were ancillary support staff, while others were caregivers and patients. Next. In Vietnam, ancillary support staff have a role of distributing food and drink on own wards, so they have a high frequency of moving around the hospital. However, they were not well equipped with the knowledge and skills needed to prevent infection. To understand why and how ancillary support staff were popular in this outbreak, we visit their accommodations and interview their movement inside the hospital. They live in, you can see in here, they live in a small enclosed place. Only 15 to 20 square meter may contain 10 to 12 people inside. They do almost casual living activity together. However, they were overlooked in the outbreak response, which is mainly focusing on the clinical staff, patients, and caregivers at that time. Next. Our findings provide evidence to Vietnam Ministry of Health and the board of other health facilities to prevent disease in healthcare settings. We highlight that the disease does not focus on particular groups of people. It is important to prevent disease for all people inside the hospital. We also reveal the potential of social network analysis to understand the SARS-CoV-2 infection patterns in the hospital and similar contexts. According to our evidence, we recommend to monitor all employees with high-frequency movements for SARS-CoV-2 infection, regardless of their position and professions. Thank you. Next. So there are some people and organizations I would like to send a special thanks to contribute for these presentations. Thank you.
Thank you very much, Anne. That was excellent. We're all clapping. So the floor is open for questions. I've got some questions coming through on the Google Sheet. So Ngoc-Anh, one question is, how did you identify the connections between cases? Did you interview them?
Oh, okay. Can you get back to slide number? Just a moment. Can I get back to slide number 25? Number 5, sorry. Okay. As you can see in here, the data source is come from 3 sources. Firstly is the case interviews. We interview the confirmed case about the exposure and the workplace connections. Interview them 14-day history travel, whether they contact with other case, confirmed case, or potential exposure source. And we also take the data from hospital surveillance system, the movement monitoring, mobile checking, and video surveillance. The investigator was separated into many teams by activities, contact tracing, testing, movement monitoring, so on and so forth. I'm not a member of movement monitoring, so I don't have much information about it. However, according to my understanding, after the confirmations, the case were interviewed by a standard form for the history for 14 days from the date of symptom onset or date of confirmations, whichever came first. Then the patients were asked to use their mobile phone number for mobile checking to support the contact investigations. They can miss some information due to the recall bias. If they refuse the checking, they have to commit with the information fulfilled. Most of our case were post their COVID-19 status on social media, the Facebook and Zalo account to inform other people. So many people who have close contact to the confirmed case will sell presentations at healthcare facility before the health staff approach. So it is excellent in Vietnam. You don't have much human resources to investigate the close contact list.
Thank you, Ngoc-Anh. A couple of other questions. One person has asked what social network platform was used.
Okay. So the social network support serve for the main function to find the important case in the network. So for this project, with the informations of case interview and epidemiological investigations, we highlight the important ancillary support staff to infection transmissions. According to the statistical analysis, I show that I will use the chronic centrality, between centrality, and degree centrality. It is the three most basic metrics for the social network analysis. So the network in here concrete the evidence of important to prevent disease for all people inside the hospital, regardless of their position and profession.
I think it was actually, the question was more about what package, but I think one of your colleagues has answered. That's okay. So a couple of other questions though. We've got quite a few questions, which is good. So one is, who employed the ancillary staff, and can you explain why there's more females than men?
Okay. So can I get back to slide 13? Okay. So in Vietnam, ancillary support staff have a role of distributing food and drink on own work, and especially in no. Can I get back to the slide 13? Slide 13, please.
1-3. So Taiwan, just one, yeah, one more slide, yeah.
Okay. So the ancillary support staff have a role of distributing food and drink on own work in Vietnam. I think in Australia, they don't have ancillary support staff in the hospital, right? So most of them were in female. The ancillary support staff, the characteristic of ancillary support staff were female and in the middle age. So they have a high frequency of moving around the hospital to distributing the food and the boiled water to around the hospital. So it is a question, right?
Yeah.
Is the answer of the question? Yeah.
So another question is, could the cases in the hospital be due to sources from outside of the hospital, so infected in the community?
Yes, we have 3 outside secondary case outside the hospital, but all of them were only connect with the confirmed case inside the hospital. They don't have a travel history or contact with other potential source outside the disease, outside the hospital. So, however, we failed to find the initial source of hospital transmissions because we did not perform the genome sequencing to all confirmed case at that time, because it's very beginning of outbreak in Vietnam, the COVID-19 outbreak in Vietnam. Yeah.
Okay. And I have a question for you, Ngoc-Anh. You've said that social network analysis is important, and I agree that it is, but can you do it quickly enough in an outbreak like this to be able to make decisions for public health?
Oh, thank you for your question. It's a very interesting question. So it is our concern about how to implement quickly the social network analysis to provide evidence for to preventing the disease in hospital. So it is actually in Vietnam, it's not popular to use social network analysis to investigate the disease. So in this outbreak, it is a lesson known. Actually, the social network analysis performed along with the outbreak, but it's mostly done after the outbreak get controlled. So although it's helpful, it takes the lesson learned for us to implement quickly for the next outbreak.
Yeah, good. Great work. Well, thank you very much for your presentation. There are a couple more questions in the chat, so I would encourage you to respond to those directly. We're going to move on to the next presentation, which is Dr. Yang Li from Taiwan FETP. So Dr. Li is going to present on the epidemiological investigation of the first locally acquired case of coronavirus disease 2019 identified by influenza surveillance, Taiwan, February 2020. Thank you very much. Dr. Lee. You there, Dr. Lee?
Okay, we unmute our voice. Yes.
Okay.
Oh, do you hear me? Okay.
Yeah, we can hear you. Thank you.
Okay. Good morning and good afternoon, everyone. Next, COVID-19 and influenza share similar clinical presentations. Taiwan CDC has conducted an enhanced surveillance program for COVID-19 since February 12. Severe complicated influenza is a notifiable disease in Taiwan. It's defined as influenza-like illness patients who die or need intensive care due to severe complications. These patients are reported to the existing influenza surveillance system and tested for influenza virus. Severe complicated influenza patients with negative flu test were retrospectively tested for SARS-CoV-2. During January 31st and February 15th, a total of 113 specimens were tested and one was tested positive for SARS-CoV-2, who was the index patient. Next. Based on preliminary information, the index was a 62-year-old male and had underlying conditions of hypertension, diabetes, and hepatitis B. He was reported as severe complicated influenza on February 3rd and was tested negative for influenza on February 5th. Then he was tested positive for SARS-CoV-2 on February 5th and died of severe pneumonia and sepsis on the same day. However, the source of infection, activities, and history of contact of the index was still unknown. Therefore, Taiwan FETP was called for investigation on February 15th. Next. Our objectives are to identify activities and clinical course of the index, trace close contacts of COVID-19 cases, and prevent virus transmission. Next. We conducted a case investigation to identify contacts of COVID-19 cases. COVID-19 cases are defined as persons who were tested positive for SARS-CoV-2 by RT-PCR. We interviewed his family members, healthcare workers to identify activities and clinical course of the index. In laboratory investigation, the source swab was tested for SARS-CoV-2 by RT-PCR. In environmental investigation, we reviewed infection control practices and medical records in the hospital and identified aerosol generating procedures during the hospitalization. We also checked the surveillance videos in the clinic and hospitals to evaluate the risk of infection. Next. Close contacts of COVID-19 cases are divided as persons who had contact with cases with 2 meters for longer than 15 minutes, while cases were symptomatic, or healthcare workers who provided medical care or performed HGP without appropriate personal protective equipment. And close contacts were tested for SARS-CoV-2 based on the risk of infection and quarantined for 14 days after last exposure and retested if they became symptomatic. Non-close contacts are defined as persons who contact with cases over 2 meters or less than 15 minutes, or healthcare workers who provide medical care or performed HGP with appropriate PPE. Non-close contacts have conducted self-health management for 14 days and were tested if they developed symptoms. Next. The index was a taxi driver and had no travel history in the past year. Family members saw the index coughed several times during a family lunch on January 27. Therefore, he visited 2 pharmacies and 1 clinic for medical treatment on January 28, February 1st, and 3rd, respectively. Next. We identify 11 close contacts of the index among family members. As figures show, 10 had eaten lunch with and talked to the index. Another one was his ex-wife, who had a physical contact with the index in ICU during hospital visit. 4 family members are tested positive for SARS-CoV-2, including case 2, case 3, case 4, and case 5. All 4 secondary cases had eaten lunch with or talking to the index without a mask and within 2 meters. Because his cough got worse and developed shortness of breath, respiratory failure, he was admitted to the outpatient of a hospital and transmitted to the emergency room on February 3rd. Then he was isolated in an active pressure isolation room and ventilated with a closed suction system in an ICU on February 4th and died on February 5th. Next. We found that airborne precaution was implemented during February 3rd to 13th, and surgical mask was used instead of N95 masks when caring for the patient during February 14th to 15th. Therefore, healthcare workers who wore surgical masks in ICU are all listed as close contact of the index. Next. So we identified 28 close contacts among healthcare workers in the hospital, including 1 doctor, 21 nurses, and 3 assistants, and 3 respiratory therapists. All of them were tested for SARS-CoV-2. However, none tested positive. Next. In summary, 39 close contacts of the index were identified, including 11 family members and 28 healthcare workers. And we also identified 297 non-close contacts, including workers in healthcare settings, in clinics, pharmacies, taxi company, restaurant, and passengers. None of symptomatic non-close contacts were tested positive. In total, 4 family close contacts tested positive, and the family attack rate was 36%. Next. In total, we identified 84 close contacts and 177 non-close contacts of 4 secondary cases in different settings, including family, neighbors, clinics, co-workers, restaurants, and funeral service. None of them tested positive for SARS-CoV-2. Next. Our investigation has limitations. We are unable to identify the source of infection because more than 14 days have passed since the onset of the index, and family members are not sure about exact activities and the onset date of the index. Due to record bias of family members, some contacts may be missed and not be traced. Next. In conclusion, we identify a COVID-19 patient by existing influenza surveillance. Second, the index caused COVID-19 transmission within the family by eating meals or talking without protection of the mask. Third, no healthcare workers were infected, which indicates the importance of wearing PPE and early isolation of undiagnosed patients with pneumonia. Finally, we didn't find further transmission of the virus from this family cluster. Next. To prevent outbreaks, we recommend enhancing COVID-19 surveillance by testing influenza-like illness patients with pneumonia for SARS-CoV-2. So, Taiwan CDC continues to detect COVID-19 through influenza surveillance. Second, family close contacts of COVID-19 patients should be traced, tested, and quarantined as early as possible. Third, healthcare workers should follow infection control practices and use appropriate PPE when caring for patients with pneumonia of unknown etiology. Next. Thank you.
Thank you very much, Dr. Lee. The floor is now open for questions. I might start with one. You have recommended that influenza surveillance helps, severe influenza surveillance helps identify COVID-19 cases. I'm wondering whether you have seen cases that have been co-infected with influenza and SARS-CoV-2.
Do you mean the co-infection by influenza and SARS-CoV-2?
Yeah.
Oh, the index case, may I have page?
Because this patient was negative, but I'm wondering if you found that they were positive, would you stop looking for SARS-CoV-2, or is it on the respiratory panels?
Oh. In our investigation, we didn't see any co-infection of influenza and SARS-CoV-2. Yeah.
Okay, thank you. So a couple of questions coming through. So one question from Taran Bagatna is, what was the difference in secondary attack rate for close and non-close contacts? How did that influence your contact tracing strategy?
Oh, yes. There are differences in secondary attack rate for close and non-close contacts. For close contacts, we only tested positive case among close contacts, and the total close contacts of this investigation is 123, and then 4 of them were tested positive. However, in non-close contacts, we identified 497 close contacts, and 0 were tested. For none of them tested positive.
So you did test them, that they're non-close contacts?
Symptomatic non-close contacts, we will test them.
Okay, great. Another question to you is, how do you define adequate or inadequate personal protective equipment?
May I have page 25? As this table shows, the appropriate PPE was defined as in outpatient and emergency room, healthcare workers should wear surgical mask. And for persons who transfer patients, they need to wear a N95 mask, gloves, and a gown. In ICU, healthcare workers need to wear a N95 mask, gloves, and a fluid-resistant gown, and a face mask, and a hair cover.
Thank you. Are they your current infection control recommendations?
Do you mean the healthcare worker in hospital follow the infection control? Yes, yeah. They follow the infection control measures, but in last few days, because of the X-ray result of the index improvement, so part of the healthcare workers use surgical mask instead of N95 masks in less than 2 days during February 14 to 15.
Mm-hmm. Okay, question from Alden Henderson. How did the household contact differ from the hospital contact?
Sorry, I didn't follow your question. Could you repeat it again?
Yes, I can. So the question is, what is the difference between the contacts in the home compared to the contacts in the healthcare setting? What do you think was the difference that might explain the different attack rate?
Actually, the family close contacts, including household contacts and non-household close contacts of his family members, and in hospital contacts, most of them are healthcare workers, such as healthcare workers, including doctors, nurses, radiologists, respiratory therapists, laboratory technician, and administrative staff, clinic staff, patient transport staff, and a driver. And in family contacts, we listed in our application is the who have hospital visit. That is his ex-wife and participant in a family lunch on January 27.
Okay, thank you. A question from Abdulel Manouf. What measures were taken for non-close contacts? Did you find significant importance in tracing non-close contacts?
In our investigation, we track non-close contacts and only tested if they develop symptoms. I think although we are not identified any positive cases in our investigation, I think it should be traced either to explain the importance of close contacts and non-close contacts in contact tracing.
So were non-close contacts put in quarantine?
Non-close contacts are put in self-health management, and they will traced by local health bureau. They will trace their symptoms every day.
But not quarantine, so they just self-monitoring their health.
Yeah, they are educated to keep social distancing and keep the face, keep wearing mask when they go outside.
And is that still your current advice in Taiwan for non-close contacts?
Oh, yes.
Good. You are doing very well. So I think that's really all of the questions. Most of the questions that have been put up, you have addressed them all. It was an excellent presentation. Really great to go back to the first cases in the outbreak and see how it started. So I'd just really like to congratulate you on a really fantastic presentation. So thank you very much, Dr. Lee.
Thank you.
Okay, so our next presenter in this session is Dr. Tan Seok Hong from EIP Malaysia. Dr. Hong will be presenting on a review of 5 years between 2014-2018 of tuberculosis mortality in Kedah, Malaysia 2020. How far are we in achieving the Sustainable Development Goal target? Thank you very much, Dr. Hong. You may start, Dr. Hong.
Hello. A very good morning and afternoon to everyone. Today, I shall be presenting a review of 5 years tuberculosis mortality in Kedah, Malaysia. How far are we in achieving the Sustainable Development Goal target? Next. Tuberculosis is one of the top 10 causes of death globally and the leading cause of death due to a single infectious agent. In 2019, an estimated 1.4 million people died from tuberculosis, with 10 million new TB cases diagnosed. Probability of developing the disease is much higher among people living with HIV and people affected by risk factors such as undernutrition, diabetes, smoking, and alcohol consumption. Next. Ending the global TB epidemic has the SDG target of 90% reduction in TB deaths by 2030 compared to 2015, aiming for a 35% reduction by 2020. Next. This review is focused on Kedah, a state in northern Malaysia with a total population of 2.2 million. It has a multi-ethnic society with good access to public healthcare facilities. Next. In 2019, the TB incidence rate globally was 130 per 100,000 population and mortality rate was 16 per 100,000 population. Malaysia is classified as a country with intermediate burden of tuberculosis. However, although the mortality rate globally had reduced, Malaysia's TB mortality rate had increased from 5.6 to 6.8 per 100,000 population. Next. TB mortality rate in Kedah state, shown by the blue line, was initially lower than the TB mortality rate in Malaysia, shown by the orange line, up to 2013, but has since overtaken the national mortality rate since 2014. Next. The objective of my review is firstly to study the trend of TB mortality in Kedah state to see whether it is in alignment with the SDG goal of 90% reduction in TB deaths by 2030. Secondly, to identify the risk factors associated with TB mortality. And thirdly, to recommend measures to reduce TB mortality. Next. This was a cross-sectional study. Data from 2014 to 2018 was collected from the MyTB system, which is a Ministry of Health TB surveillance registry, as well as from TB mortality reports. Next. Mortality rates and case fatality rates were calculated following WHO definitions. All TB cases ending up in death were included in the analysis. Next. The following risk factors, which included socio-demographic and comorbidity factors, were studied. Logistic regression analysis was performed, comparing TB death group with a live and successful treatment group. Next. And these are the results. When we compare TB mortality in Kedah to the SDG target, number of deaths initially showed a decline, but has increased away from target since 2018. Next. Percentage difference between actual number of deaths and SDG target had also increased to 41.5% in 2019. Next. All-cause mortality rate, shown by the blue line, decreased to 6.7 per 100,000 population in 2017, but has increased to 8.5 per 100,000 population in 2018. All-cause mortality rate, excluding HIV, follows a similar pattern, while the case fatality rate, shown by the gray line, is between 11 to 15%. Next. Out of a total 862 deaths, 39% were directly due to TB, while 58.6% were indirect or non-TB death. A vast majority, 90.5%, were newly diagnosed cases. Next. 68.9% of deaths occurred during the intensive phase of treatment, while 31.1% occurred during the maintenance phase. According to days of treatment, 41.9% of deaths occurred in the first 2 weeks, while 13.7% occurred within 2 to 4 weeks. Next. Although PTB smear positive contributed 70.7% of total deaths, case fatality rate did not differ much between the different types of TB. All were around 12 to 14%. Approximately half of the PTB deaths presented with moderate chest X-ray changes, while 13.8% were already advanced. Next. Cases who presented with advanced chest X-ray changes had a much higher CFR at 35.9%, followed by those with moderate changes. Next. CFR increases with age, with those aged 65 years and above having the highest CFR at 27.3%. Next. Males contributed 74.7% of deaths and have a higher CFR compared to females. Next. Overall, 98.4% of deaths occurred in Malaysians. Malays contributed 81.7% of deaths. However, the case fatality rate did not differ significantly by ethnicity. Next. Rural residents contributed 66.1% of deaths and have a higher CFR compared to urban residents. Next. Cases with no permanent income contributed 73% of deaths and have a higher CFR than those with permanent income. Next. In addition, we looked at the case fatality rates by comorbidities. Bearing in mind that one case may have more than one comorbidity, the percentage of TB deaths who were HIV positive was 13%, diabetic 32.8%, and smokers 39.4% respectively. Cases with HIV had the highest CFR at 36.5%. Smokers initially had a higher CFR compared to diabetics, but from 2016 to 2018, diabetics had a higher CFR at 17.2% versus smokers 13.2%. Next. From our multiple logistic regression analysis, we found that the significant risk factors for all-cause TB mortality were underlying diabetes, HIV positive, and having moderate or advanced chest X-ray changes at presentation. Next. Other risk factors were elderly, age 65 years or older, male gender, and having no permanent income. Location of residence and type of TB were initially found to be significant on univariate analysis, but became insignificant when adjusted for in multivariate analysis. Next. So from the findings, Kedah is not achieving the SDG target of reduction in TB deaths as all-cause mortality had increased in 2018. One of the possible reasons is due to cases presenting at an ill and late stage, as we saw that among those with pulmonary TB, 64.6% presented with moderate to advanced chest X-ray changes. Next. Mortality occurring within the first 14 days was 14.9%, whereby some of the mortality may have been reversible if anti-TB therapy had been started earlier. WHO recommends diagnosis within 2 to 3 weeks of symptoms initiation. Next. Most early deaths with TB-HIV co-infection are due to TB itself, emphasizing the importance of starting isoniazid prophylaxis in HIV patients early. The finding that the TB case fatality rate in Kedah among diabetics had overtaken smokers since 2016 is worrying, as the state has a high burden of diabetes, with 1 in every 4 persons being diabetic. Next. So these are some of our recommendations. First, enhance screening strategies for early detection among vulnerable groups, focusing on the elderly in rural areas and for those with comorbidities, especially those with HIV and uncontrolled diabetes. Secondly, implement measures to address the issues on delay in seeking treatment by increasing the public and healthcare providers' awareness on TB and conducting further study to identify the factors leading to delay in seeking care among patients. Next. In conclusion, Kedah is not on track to achieve the SDG target of 90% reduction in TB deaths by 2030. Cases who were elderly, male with no permanent income, diabetic, HIV positive, and presenting with moderate to advanced chest X-ray changes were more likely to die. Recommendations to reduce TB mortality include enhancing screening strategies and addressing the factors contributing to delay in diagnosis and treatment. Next. These are some of my references. Next slide, please. I would like to acknowledge the following people who made this study and presentation possible. Next. And with that, I thank you.
Thank you very much, Dr. Hong. That was an excellent presentation. The floor is now open for questions. There is a question in the chat which is, what are the different causes of indirect or non-TB deaths associated with that you present?
Okay. Some of the causes of indirect death include secondary infection. So cause of death given as septicemic shock, for example, and severe pneumonia, but not directly due to tuberculosis. So these are some of the examples.
Okay, great. A question from Sushil Chavan. As per your presentation, smoker is a comorbid condition along with HIV and TB. Can you quote any reference for that?
In the WHO global report on TB, smoking is one of the risk factors besides HIV, undernutrition, and diabetes. So it is, there are studies which show that smoking is a risk factor.
Okay, great. One question from me. I notice that people without an income have a very strong risk factor for mortality with TB, yet you didn't make any recommendations about screening people without an income or who were poor. So interested in your comments on that.
Okay. So for those without any permanent income, these included the elderly who are retired from work, those who are unemployed, and also some who were substance abusers because they are usually unemployed as well. So in the recommendations, screening for the elderly is recommended. And of course, for those substance abusers, they are also prone to HIV infection, and we definitely recommend. It is compulsory for HIV patients to be screened for TB.
Okay, great. A question from Taran Bahatnagar. What was the proportion of transfer out and missing cases that were excluded from the analysis? Could that influence the identification of risk factors for TB mortality?
Okay, give me some time to open my data set. It is not a very high percentage. Is it possible for me to get back on this? I will type it in the chat box because I need to open my data. Sorry about that. It's a low percentage. I think about less than 10%.
A question from Tom Weiser. Is there any recommended screening for TB for people with diabetes?
Oh, yes. In Malaysia, being diabetic is actually one of the high-risk groups which we highly recommend for TB screening, especially those with uncontrolled diabetes with a poor HbA1c or poor random blood glucose. So it is already one of the strategies in our Malaysian screening program for a high-risk group for TB.
Okay, great. A question from Alden Henderson. How representative is your study population to everyone who has to? Are there groups who were underrepresented in your study?
Because in Malaysia, TB is a disease which is mandatory to be notified. So if the person seeks medical attention, and is diagnosed to have TB, then definitely it will be picked up by our national mandatory notification system. And in Kedah State, which is where my study is located, there is good access to public healthcare facilities, because we have we have 9 hospitals, we have 60 health clinics and 200 over community clinics. So issue of accessibility should not be an issue.
Okay, great. And another question from Martyn Bilha from the Bangladesh FETP. What is the current TB screening strategy in the area?
So the current screening strategy is to screen high-risk groups, for example, close contacts to TB patients, and also HIV positive patients, those who are diabetic, especially those with uncontrolled diabetes, the elderly, and also prisoners. So these are the strategies which we are using currently.
Okay, great. There's a few more questions in the chat. I think we've got time for one more question. So I will take a question from Taran, which is, what could be the reasons for men being at higher risk for TB mortality? And how did you identify the confounding factors in order to adjust the odds ratio in multiple logistic regression? What was your modelling strategy?
Okay. I think because males, there are more smokers among males compared to females. And as you can see, 30% of the TB patients are smokers. So that could account for the higher risk in males. Also, again, there are more males tend to be substance abusers compared to females. So that is another contributing factor. As for how I adjusted in the multiple logistic regression, firstly, I did the single logistic regression using all the risk factors that was listed. And for those which were significant on simple logistic regression, I put it into the multiple logistic regression. And so that is how I got the significant risk factors.
Great, that is really fantastic. So I think we will call that presentation to a close. If you can answer those other questions in the chat, that would be really great. Really fantastic presentation, and thank you very much.
Sure, thank you very much.
Great. It is a bit strange having these presentations and no clapping afterwards, but I'm sure you're all clapping where you are. So our final presentation in this proffered paper session is Ratchadaporn Papwijitsil from the International FETP in Thailand. She's going to be presenting to us on an investigation of healthcare-associated measles infection in a regional hospital, Phuket Province, Thailand, July to October 2019. This happened last year, pre-COVID. So we're hearing about some non-COVID work, which is excellent. So thank you very much. You may start.
Yeah. Good morning and good afternoon, everyone. I'm Ratchadaporn Papwijitsil from FETP Thailand. Today, I would like to present an investigation of healthcare-associated measles infection in a tertiary hospital, Phuket Province, Thailand, June to October 2019. Next. Introduction. Measles typically presents with fever, cough, coryza, conjunctivitis, and Koplik spots. Rash may appear 3 to 5 days after symptoms begin. The virus is transmitted by direct contact, droplets, or airborne spread. The incubation period usually is 10 to 14 days. At present, Thailand's EPI program has provided a first dose of measles containing vaccine to children at 9 months old and second dose at 2.5 years old. Next. About healthcare-associated infection, it is the infection detected within 48 hours of hospital admission in patients that had previous contact with healthcare service within 1 year. About in measles, because of measles severity, patients often seek care in healthcare settings, posing a high risk of transmission to other patients and healthcare personnel. Next. Background, on 15th August 2019, we were notified that there was a cluster of suspected healthcare-associated measles infection in a tertiary hospital in Phuket Province in July 2019. So the investigation was conducted. Next. Objectives: to confirm the diagnosis of the outbreak, to describe epidemiological characteristics of the outbreak, to determine factors related to the spreading and identify source of infection, to provide appropriate recommendations and control measures. Next. Method: we review situation of measles and vaccine coverage in Phuket Province and perform active case finding by reviewing medical records and interviewing patients, caretakers, and healthcare personnel. Next. Case definition. Suspected case was anyone presenting with fever, rash, with at least one of the following signs symptoms: cough, coryza, conjunctivitis, or colic spots, and having history of work or visit the tertiary hospital 7 to 21 days before the onset. Probable case was suspected case who had history of contact with a confirmed case. Confirmed case was suspected or probable case who had positive measles IgM and or positive PCR for measles. Next. Laboratory investigation. We send serum IgM or throat swab PCR for measles. We analyze location linkage by social network analysis. Environmental study was done by behavioral survey and interviewed healthcare personnel, patients, and caretakers. Next. Here's come for the results. The left graph shows number of the cases in Phuket was high since the end of 2018 and gradually increased from the beginning of 2019. The right graph shows MCV coverage did not reach the target. Next. There were totally 31 cases that met case definition. Male to female was 1.2 to 1. Inpatients to outpatients was 1.4 to 1. The right pie chart shows most of the cases were pediatric patients. 19% were healthcare personnel. Next. The upper bar chart shows age group under 9 months old was the highest proportion. The lower graph shows the most complication was gastroenteritis, followed by pneumonia. The table shows patients who were under 9 months old were mostly affected by complications. Next. For symptoms and signs, most patients had fever, rash, coryza, and cough. Next. Here is the epidemic curve. Most of cases were confirmed. The onset of the first case was on 5th July. The number of cases was peaked in early August. We was notified on 15th August due to uncontrolled outbreak. Field investigation was conducted after that. No more cases since 14 September. Next. The first case was an unvaccinated 9-year-old Myanmar boy. His onset was on 5th July. He went to the hospital on 8th. At ER, he was diagnosed as viral pneumonia and viral exanthem. He went to pediatric OPD for chest X-ray, where met case 2 and 3. At pediatric ward, where case 4 and 5 were admitted before, he was nebulized. On 9th July, the diagnosis was changed to suspected measles. Then he was isolated. Laboratory results confirmed that he was measles. Next. This is social network analysis. We can visualize that pediatric OPD and pediatric ward were the places that most of the cases had epidemiological linkage. Next. Laboratory results, 5 cases were positive for measles PCR with DH genotype. For genome sequencing, 100% match of all 5 cases. 70% of 30 cases were positive for measles IgM. Next. Environmental study start from ER. There was no isolation room, no screening system for fever with rash, pediatric OPD. There was no screening desk, no standard isolation room. Next. Move to pediatric ward. It was divided to general ward and private rooms. In the outbreak situation, the private rooms were adapted to be the isolation room. All 16 pediatric inpatients were admitted here. We found the majority of cases were delayed, diagnosed, and isolated. Next. Discussion. The outbreak was the healthcare-associated infection with measles caused by the DH genotype. Delayed diagnosis and isolation contributed to the transmission of the outbreak. Corresponding to previous studies, delayed diagnosis or isolation played a major role of disease transmission resulting to the outbreak. Next. From social network analysis, the pediatric OPD and the pediatric ward were the places that many cases share a social connection. Pediatric OPD was among high-risk areas of transmission due to no appropriate isolation room and no screening point, causing delayed case detection and isolation. Next. Pre-vaccinated infants were the highest proportion and tends to have higher rate of complications and mortality. Seroprotective rate in children under 1 year old in Thailand had only 26.5%. Next. Recommendations for the tertiary hospital should set up screening system for measles at the frontline units, should strengthen infection control system in the hospital, should mop up or catch up MCV to healthcare personnel and unvaccinated patients. For Phuket Provincial Health Office, should conduct MCV catch up campaign among high-risk population in Phuket Province. Next. Conclusion. This outbreak was the healthcare-associated measles infection, mainly affected pre-vaccinated children. Delayed diagnosis, delayed isolation, and poor hospital infection control contributed to the spread of the disease. Surveillance of measles and isolation precautions were recommended to prevent future outbreaks in healthcare settings. Next. That's all for my presentation today. Thank you.
Thank you very much, Dr. Papwijitsil. Questions, the floor is open for questions now. One question I have to start off is, you mentioned there was a recommendation to the Phuket Province to conduct catch-up campaigns for measles-containing vaccines.
Yes.
Do you know if that has happened? Because we're very concerned about what has happened to vaccination currently with COVID-19. So we'd be interested to know, has that happened?
Yes, in Phuket Province, it is the island in Thailand, and there are many migrants or foreign laborers working in Phuket Province. And in some community, for example, in the Myanmar migrants community, that community that communities are the vulnerable people living there. So for Phuket Province, for the Phuket Provincial Health Office should go into that community to find the problems that the people who live in that community have the health problem. For example, no vaccine or no immunization in the people who live in that community. And in some people that have poor hygiene or poor education, that the Phuket Provincial Health Office should pay attention to that community.
Thank you. So there's a few questions have come through. One from Mengyu Chen. Were all the cases unvaccinated? Were there any breakthrough infections?
Yes. There was one case that she was 40 years old, and she, from the history, from the investigation, she got 2 MMR vaccine already, but she got measles in this outbreak. But there is some limitation, for example, about the information bias, because she just only tell us about the vaccine history that she got, and we think about the secondary immune failure from the vaccine also, but no evidence to support it.
Okay, thank you. A question from Tom Weiser. What is the case notification to the government for measles? It seems you were notified long after the beginning of the outbreak. So can you tell us about how cases are notified to government?
Oh, yes. Actually, the hospital staff, the epidemiologists in the tertiary hospital, that observed that there was a cluster of pediatric inpatient with measles. So they notified to DDC. They notify us that they suspected is that related to the healthcare associated infection or not. And then they notify us.
Yeah. So is it mandatory? It's mandatory by law to report measles cases to the government?
No, just only a cluster in there was no the number, the exact number that how many cases that should be notified. But if the outbreak happens in the closed places, for example, in prison or in school or in in hospital setting, they should notify to the central government.
Okay, so it's clusters. So a question from Masum Billah from Bangladesh FETP. Did you visit the catchment community of the hospital? Were there any outbreaks in the community at the same time?
Yes, there was a small cluster of measles outbreak in Myanmar school, but just only few cases in that school. Yes, it happened before outbreak in the hospital.
Okay, that's great. A question from Taran. What was the secondary attack rate by pediatric general private ward? How would you explain the difference?
Could you please go to slide number 13? From this epidemic curve, we can see, if we can imagine the wave of the graph, we can see the peak was in early August and a peak again in mid-August. That can show like the secondary wave and the tertiary wave of the outbreak. So actually, we cannot identify the secondary case exactly, but we can assume that the secondary infection that can spread in between the end of July to the early of August. But most of cases were the children under 9 months old in the pediatric ward.
Okay, great. So a question from Dr. Jaffrin from FETP Bangladesh. Why are the pre-vaccinated children having more measles? Is there any other study to see whether there is any problem with vaccination?
In pre-vaccinated children are the children under 9 months old that they totally not get the vaccine.
Yeah.
Absolutely. And this age group tends to have like a maternal antibody from the placenta and transmit and go through the children. But in many studies show that the remaining maternal antibody in this group is disappear maybe from 3 to 4 months after birth. So this group is higher susceptibility to measles infection, of course.
Okay, thank you. Another question here with a comment. Nice presentation. Could you tell us something about the sensitivity status of measles surveillance in Phuket Province? So how sensitive is the surveillance?
Sensitivity of status, measles surveillance.
Yeah.
In this study, we did not calculate. We did not perform to do the sensitivity status of the measles surveillance.
Can you give us any comments about how sensitive you think it is? Is it detecting most of the cases of measles, or you think there are problems there?
Yes, the sensitivity that about the measles surveillance in Phuket is quite high. But from you can see from the review in the slide number 9, please. Please go to the slide number 9, please. Yes. Yeah, the left bar graph shows the review situation of measles cases in Phuket Province. You can see the blue line is the 5-year median. 5-year median of the number of cases in Phuket Province. You can see it's just a few cases in 5-year median that I have reviewed. So the sensitivity in the past 5 years is not quite high, but I think after 2019, the sensitivity is higher.
Well, certainly able to detect cases. Another question from Suganya Barani. If pre-vaccinated children are affected, do we have to recommend an earlier vaccination schedule to avoid infection?
Yes, in Thailand, especially in the 3 southernmost provinces in Thailand, we recommend that for the provider should give early vaccination to the children that can give since 8 months old, especially in the endemic area of measles. So in this situation, I think if the situation in community get higher infection rate, the recommendation should change from 9 months old to 6 months old, also like at 3 southernmost of Thailand.
Okay, there's a couple more questions in the chat. I'm going to ask you one final question, then if you can go into the chat and answer the others. So the final question from Tom Weiser is, how many of the healthcare personnel were unvaccinated? Is it required?
I have no data about the unvaccinated healthcare personnel, but in this outbreak, we recommended for all healthcare personnel should be provided for the measles containing vaccine to all healthcare personnel, especially who working in the front line units. For example, OPD or ER, something like that.
Okay, that is great. Thank you very much, Dr. Papwijitsil. Really great presentation. In fact, all 4 presentations were excellent. They covered a range of different topics. We saw social networking twice, which is really good. So the front and the end. I think that really challenging questions that all presenters were able to answer well. So I just want to thank all of our presenters today, and I congratulate you on doing such great work in the field and presenting here today. So I'm going to hand over to Dr. Martyn, as this is the end of this proffered paper session. So thank you very much, everyone.
Thank you, Dr. Martyn, and congratulations to all presenters today. Now we are going to have a break for 40 minutes, and please enjoy your coffee, tea, or lunch by yourself at your program site. So in the closing, we will give a word to outstanding presentation. Please, for the audience online and all presenters, please stay with us until the last minute. Thank you.